Hello, my name is Richard Longland, and thank you for joining us today at the Patient Advocate. I'm the founder of the Arthroplasty Patient Foundation, and here today with us is a special guest to talk about Lyme disease. Lyme disease is a very controversial topic for reasons we'll get into today, but today we're really just going to focus on Lyme disease diagnostics, both from a laboratory perspective and from a clinical perspective. Here today we have Bob Giguere from IGeneX. So Bob, if you would, tell us what IGeneX does.
IGeneX laboratory focuses on Lyme and its co-infections only. We don't do a broad array of other micro and infectious disease work, but we believe we do the most highly technical and accurate testing that's available for Lyme, and it's pretty much been played out pretty accurately that way throughout the last 15 to 20 years. So we're around doing our best that we can.
Okay, so we'll get to some more basic questions later, but I want to give you some tough questions that that I've heard from patients and doctors all around the United States. Now, Lyme disease is sort of controversial for different reasons. We'll get into that later, but talk a little bit about why IGeneX is credible in terms of the certifications. Now, I don't want to get into 10 or 15 minutes of definitions, but you're a CLIA certified laboratory, is that correct?
Absolutely. CLIA licenses all laboratories in the United States. When physicians try to say, well, it's not an FDA approved lab, there is no such animal. The FDA does not approve laboratories. The FDA reviews equipment and test kits that are used in individual laboratories, but they don't come into your laboratory and say whether you're doing a good job. CLIA does that, and states do that. Now, there's accreditations you can also get, such as CAP accreditations, the College of American Pathology. It says proficiency testing in areas. And so, yes, we are CLIA approved and licensed in all states in the United States. We've been that way since 1991. So, if you run your own in-house assays, homegrown, shall we say, you have to do a lot of extra things to keep the CLIA licensing and your state approvals in order. So it's a lot harder to do it that way, but we have found over the years that most of the testing for Lyme falls far short in a kit form, and that doing it the hard way seems to work a lot easier or a lot better, especially for clinicians who are dealing with this problem.
Okay, so let's get into the testing. So is it primarily or exclusively blood testing?
Mostly, most of our testing is in blood, whole blood. We have some urine assays because we do, of course, both PCR and a urine dot blot assay that was originally developed at the CDC. But most of our testing, yes, is serological testing looking for immune responses, although there are a lot of differences between our serological testing and some that you will get from the major reference labs.
Okay, so let's get into that a little bit, just to drill down. So the nature of your test, is it looking for responses to, or is it actually looking for the bacteria that causes Lyme itself?
Okay, we can do both. Most of the medical community likes to look at serological testing. That's the immune response of the body to an infection. So yes, we do serological testing, and there are a couple different techniques you can use. There's an ELISA or an IFA, and there's also the Western blot. Now the IFA, ELISAs, they work reasonably well. The EIAs, those are the tighter tests you would get from a major laboratory. They're, again, looking for specific immune antibodies produced by the body against the bug that's in the body at the time.
Okay, and co-infections, just to touch on that a little bit, when I interviewed Dr. Eva Shapi several years ago for my film, Why Am I Still Sick, she referenced one test in which researchers actually went out into the field in Connecticut and dragged the sheet to see how many ticks they could actually catch, and they caught hundreds. And then they actually looked in the guts, the bellies of these ticks for Borrelia, the bacteria that causes Lyme disease. And they found that 84% of those ticks also carried other stuff. We call these co-infections. So let's talk a little bit about co-infections. Now, your lab also tests for these?
Yes, we do. We do both screening tests for them and, again, the PCR test, and that's actually looking for the bacteria. So we do both in our laboratory. We look for the major infections that come with Lyme disease that we see when the immune system gets suppressed, be it anaplasma or ehrlichia, depending on your place of your HG, being the West Coast, the HG anaplasma here. Babesiosis, there's a couple major strains that are causing problems now, not just the original microti here. We've seen the upcrop of the Duncani, and of course Bartonella-like syndrome, which is very similar to cat scratch. Those are the three major that we test for, although we do some rickettsia testing. Those three seem to appear with a significant number of patients who've had Lyme for some period of time. Because Lyme, as you know, it's insidious. The Borrelia does go around the back of the person's immune system, start to affect you with things called interleukins, which is suppressing your immune system over time. And by suppressing and deregulating it, it causes the opportunistic infections, these co-infections, to start to rear their ugly heads a lot more aggressively. So yes, we do testing for the co-infections. Our major focus is still trying to get at the root of the problem, and that is finding all of the absolute people who have Lyme disease and not being misdiagnosed with something else.
So is there any way of knowing if the viewers in the audience, when they go to see their doctor, their PCP or the people that they see that might have sort of insidious subclinical problems or even more obvious,
Yeah.
What kind of testing is actually done throughout the United States right now? Do you have any inkling of that?
Sure. What usually is done, first of all, is a titer test. It's an immunological test done, again, looking for immune response. In a 96-well plate, it's an ELISA, and they call it titer. So the doctor, when the patient shows up, will usually order that as the first round. That's what the originally was set out back in 1990s as the two-tier approach testing for Lyme disease, which is to do a screening test. But if you really read down, you'll find that even the FDA doesn't want it called the screening test for Lyme. They want it called initial test. The reason is other screening tests don't miss. They know they're going to pick it up. But if you go to the FDA websites, you'll find that they call the initial test for Lyme, not a screen test for Lyme. And the second test is not a confirmatory or Western blot in that two-tier approach. According to the FDA, they want that called a supplemental test. So what those are clearly stating to us out in the community is these tests aren't of the accuracy and specificity that we get with screening tests for HIV or for hepatitis, because they're going to miss. We've seen numerous studies that show the ELISAs and those titer tests picking up anywhere between 35 and 55% of the cases of Lyme. And so there's a significant issue in accuracy with those tests.
Well, let's focus in on that, because this is very concerning for anyone that suspects they might have Lyme. Mm-hmm. Let's look at this from another perspective. Recently I interviewed Dr. MacDonald, who's a world-famous researcher, Lyme disease doctor, and I was stunned to learn that there are many strains of Lyme disease. Now, correct me if I'm wrong, there's 37 or more strains of Lyme disease that cause problems in us humans, but the test that is available throughout the United States is only looking for one strain. That's the B31. Is that correct?
Well, that was the original strain that was sequenced and published in Nature back in 1995. So most of the test kits that are out there that are purchased and used at the major reference laboratories all focus on just using that one strain. And so yes, that's what they're looking for. And although it does have some cross-reactivity with some of the other strains, it doesn't pick up everything, for sure. One strain is missing it, and therein lies part of the issue. The other issue is you've got to understand Lyme disease is the great imitator. And not only is it in its symptoms, but in its presentation to the immune system. What happens in a lab test, a screening test that we do, is we'll take the human serum and we'll pipette it, or use a little pipetter and put it into a little tube of a 96-well plate. And then we pipette in the antigens that we think are specific for that disease. Now, those are all based on the B31 strain in most kits. And they're minus a couple of antibodies that were taken out back in the mid-1990s that I'll talk about later. And then we allow nature to take its place. You've taken that serum of the person and put it into this test tube with these antigens that are specific for Lyme, but the human serum has got a lot of other antibodies in it, not just to the one disease of Lyme. So they've got a lot of things focusing in there, all competing for binding sites on the antigens that are in there. Because an ELISA assay is actually an immune complex between the antibody and the specific antigen it's targeting to form a nice strong immune complex. Then we use a second antibody with a fluorescent tag on it that looks only for that strong immune complex. What happens when you've got other antibodies, which we all do, floating around, they compete for these binding sites on these antigens, and so you don't get nice strong immune complexes formed. Third step in this process after we introduce the human serum is to do a wash cycle. And the wash cycle actually removes all non-specifically bound or unbound antibodies. Well, if you don't have a nice strong immune complex between antibody and antigen in that it all gets washed away, and when we hit it with the second antibody or pipette it in with the fluorescent tag, there's nothing for it to grab to. And that's one of the major issues that we have with the ELISA or titer test. It works wonderful for other molecular, microbiological issues and infectious diseases, but for this disease, because of its ability to mimic so many others, it is not a good technique.
Okay, so that was kind of technical, but very
sorry.
clear. No, that's okay. So I want to back out of there. We're going to come back at that in another way. So there's at least 37 strains.
Right. We have a whole lot of strains.
How many does your company actually test for, though?
Well, we use 2 different strains of Borrelia. The B31, there are 3 strains in the United States, and most of them will cross over to the other active strains that cause Lyme. Now, there are 37 strains, but understand that only 5 of them have ever been found to be causes of Lyme or Lyme-like diseases in the world. So we can test for the other Borrelias if you could, but they're living well in the bodies and not causing issues. They're actually probably helping, as other bacteria do. So in your immune system, you don't need to, you want to find the ones that are specifically causing Lyme disease. So there are actually 5, as I said, strains. The newest one was they discovered, written about most recently in the New England Journal of Medicine, found in New Jersey and up on Cape Cod back in January and put in there by Dr. Krause and his group at Yale, the Miyamotoi strain. So we have 4 other strains, the Borrelia burgdorferi, we have the Lone Starry, which yes, it came from the Midwest, and a guy named Ed Masters found that back about 15 to 20 years ago. Then we have the 2 other strains from Europe, the Afsali and the Guaranay, and both of those are also seen in the United States because we see people coming and going, people travel.
Well, that's a good point. So Miyamotoi is from Japan, right?
Originally, yes.
Okay. So the viewer's going to be wondering, okay, I get it now. People are traveling from the United States, they're leaving the United States. So again, forgive me for being repetitive here, but so is your company, does your company have the technology to be able to detect these problematic bugs?
Using the Western blot that IGeneX has, we use 2 different strains of Borrelia, the B31 and one called the 297. Those 2 strains, when we mix them together, because we harvest them and keep them alive, are able to cross-react with virtually every other strain right now. We're still looking at the Miyamotoi strain. We're not sure of it, even though we have gotten positives on patients from Japan for years. Until we have sequenced out the Miyamotoi strain and have compared it against our assay, our Western blot, we don't want to say that, but we are getting positives, of course, throughout Europe, South America, even we've gotten a number of positives from New Zealand and Australia now, looking for these specific antibodies that are appropriate for Lyme.
So this is all good. I understand that. I mean, clearly your company has done its homework for many years. How many years now?
1991 to now.
Okay.
Still going.
All right. I mean, that's obviously significant. Now let's give credit where it's due to the doctors, the clinicians, the nurses, all the other professionals out there that understand that as effective as testing can be, it's not the end all. So can you sort of give us, to the extent that you can, an objective viewpoint on how clinicians are not relying entirely on these blood tests, but using their training to understand and make these assessments from a clinical perspective?
That's something that we, Lyme disease is a clinical diagnosis. We say that in all my talks, and we all try to as laboratorians. Lyme disease, the testing is at best reasonably good. I believe our Western blot is probably the best test in the United States for that, and it's been played out pretty well that way for the last 15 to 20 years at most clinicians treating with chronic or late stage Lyme. So the physician is faced with a patient who walks in with Lyme-like symptoms. Now they order an ELISA, or they're trained to order a screen test. And the problem there lies, as I always call it, the most dangerous test result we give in microbiology is a false negative. So he's got a tough case, and the tough case is where he's going to the lab testing for. And if you're making a clinical decision that says, gee, I think it's Lyme disease, but I don't want to put you on an antibiotic yet, let's make sure. Then they order a lab test, well, maybe it's not Lyme, I got a negative test. So in some states, recently in Virginia, they've actually passed a law that's requiring physicians to let patients know that the lab testing could be wrong and that we should follow maybe our clinical impressions, and physicians have to be allowed to do that, especially with this disease because of its ability to suppress immune response over time. Makes the lab testing even worse as time goes along, as the person gets sicker and sicker.
So the other tricky thing, and again, not to get into the
Sure.
aspects of microbiology, but it's quite fascinating and actually a little bit scary that Borrelia in all its different forms can infect the body and hide in the body in many different ways. Eva Shapi and Dr. Alan MacDonald discovered that actually creates a biofilm, and of course it does. Why shouldn't it? All the other spirochetes like syphilis, the one that causes syphilis rather, create biofilms. So, and these things have been found corkscrewing into human white blood cells, for example. So there's lots of different ways these things can hide, but I guess, can you reconcile that? And maybe this is another way of asking the question about relying on
Right.
lab testing.
Over time, what happens is this bug will hide in tissue, and it'll form cyst forms. When it does that, the body's immune system isn't seeing it, so you're not going to get an immune response. Usually, by throwing out what are known as blebs or other plasmid things, it actually finds out if the immune system of its host is suppressed or stressed. We find that people in the spring will get a small dose of doxy or an antibiotic. They'll have had Lyme disease, been gotten bit, and the doctor said, gee, I think it's Lyme, we're in an endemic area, let's treat you appropriately. They kind of a little underdose. The CDC criteria and things might be a little, I believe, on the light side, and this bug, we really need to treat it, I think, a lot more aggressively. But they don't, and for whatever reasons, or they feel, well, stick for a couple of days, the tissue ends up grabbing, or the bug finding its way into the tissue and hiding, waits for the immune system to get suppressed for some other reason. In the fall, it's lovely. People are getting ready for the holidays, they start getting stressed, and Borrelia starts to come back. So unlike in the spring or in the summer, where if you get flu-like symptoms, it usually isn't the flu, so the physician can make the clinical diagnosis there. Come November or December, there's flu starting to show up, other things that Lyme mimics, and now the diagnosis becomes even hazier. So they go to a lab test, and we wish that they wouldn't, especially in endemic areas, the ELISAs, they've just seen too many articles, too many published peer reviews on how poorly these tests perform. A Western blot at the basis is where you should start. If you believe it's Lyme disease in a patient and you're going to take it seriously, a good solid Western blot is what you need. That's a good place to start.
So let's talk briefly on some of the assumptions that people have about how Lyme disease is transmitted. My understanding is that there are many vectors, animals that can carry this. It's not just a white-footed mouse. It's found in robins, it's found in squirrels and chipmunks and all kinds of different little critters.
Yes.
And then also different ticks. There's what, 4 or 5 ticks that carry Lyme?
There's a few that we know of. The two here in the Northeast seem to be the Lone Star tick, which we're starting to see down along on the Long Island. We're seeing it along the coasts of Connecticut and up into Maine. And of course, up and down the Hudson Valley, the Lone Star tick is starting to show its ugly head. Unlike the Scapularis or standard deer tick, which is what has been the main cause of Borrelia here, this tick is far more aggressive. It hunts, and it will actually walk 20 or 30 feet looking for its next blood meal. But like the deer tick, what it does is it attaches to a nice, quiet, soft place on a host, gives a local anesthetic so that the host doesn't know it's there, and then starts to form a little bit of blood bubble right under the skin by first sucking out and injecting. What interesting part is when it sucks the blood out of its host, that temperature of the blood is usually of a different than what's in this, and that activates the Borrelia in the mid-gut. And that's what activates Borrelia and the co-infections to start coming through the mouthpiece and forming into that little blood bubble under the skin.
Rather ingenious design.
It's Yeah, very capable, very, very capable. And it does that for, there's a lot of controversy about how long it takes to transmit this disease. If the bug had been attached to someone else, or if it's an immune system that already activated Borrelia, there's a high probability it could probably already be in the mouthpiece. And so the injection time that everyone likes to believe is saying 24 to 36 hours could be significantly shorter.
Well, I'm glad you raised that point. I believe I saw an article on PubMed last year. It might have been from Dr. Burrascano or someone like that, that transmission has been documented in an hour or less. So to your point, of course it could happen. So I don't know where these assumptions are coming from, but I think we all need to pay caution to where it's due.
Yeah, well, all of the assumptions are based on a few very limited, well-run tests on ticks, on mice. And they were done either in Connecticut at the Connecticut Agricultural Center or out at Davis in California. And yes, it did take that long, 24 to 36 hours, to transmit disease in mice, ticks that had not been attached to anything else. In real life, science can't be that precise. We'd like to say it is, but you're absolutely right. It can be transmitted, we believe, significantly quicker than that. Only, especially across the human skin barrier, and children, their skin is a little thinner, and so we should be very cautious, especially in endemic areas. The other thing you should remember is the tick you find may not be the one that transmitted the disease. We see an average of 15 to 20 ticks on any one mouse at any one time. So, and on deer, hundreds of ticks at any one time. So when you walk through the bushes or you roll around in the ground and one tick jumps on, that doesn't mean everybody else isn't allowed in. And so there's always a possibility that the tick you found wasn't the one that actually carried or even gave you the Borrelia.
And these ticks that carry disease are found in every state, is that correct?
Oh yeah. Yeah, here in the Northeast, I always like to look at the tick population and the percentages of the diseases in it, because the tick is not a political animal. So if you do a PCR looking for the Borrelia, the bug in the tick, and 50 or 60% of the ticks carry Lyme, you have a very serious problem. It's an endemic area. All of the counties in the state of Massachusetts are endemic for Lyme. Actually, every state here from New York north, just north of New York and Connecticut, are all now endemic for Lyme disease. And co-infections are showing up because as centers test for more of these in the ticks, some nice work done at the University of New Hampshire a couple years back showed that in the greater Concord area, 20 or 30% of the ticks, 50 or 7% carried Lyme, but at least 20 or 30% of those also carried co-infections. And some wonderful work down on Cape Cod by the Barnstable County Department of Health has shown a significant number of over 50 to 70% of the ticks that are Lyme carriers are also carrying at least one or two of the co-infections.
So this is unfortunate, but I think we appreciate knowing that at least. So again, thinking as a patient advocate for viewers out there, some of them are probably thinking, well, all this is helpful, but my doctor is not on board with it. So let me put the patient advocate hat on you.
Yeah.
For those patients that are just getting a lot of resistance from their doctors and their doctors are not amenable to doing more thorough testing, right, what advice might you have for them?
There are two thought processes. There's the Infectious Disease Society of America, and there's the ILADS, the International Lyme and Associated Disease Society. These are two divergent philosophies as how to diagnose and treat Lyme disease. As you can probably guess, we are definitely on the ILADS line, and that's where we stay. And so I strongly suggest that if you think you're not getting the response that you feel is appropriate for the symptoms, it could be that you're not expressing it to the physician. The physician is forced to spend 7-minute medicine, and so he doesn't have the time to spend with you. Then it's time you became your own advocate. Look online, find an ILADS trained physician, go to the Lyme Disease Association, which is a large group of about 40 different support groups across the country, will help direct you toward specific physicians who are open-minded, shall we say, willing to look at the patient and not stay specifically within the box of, okay, you don't have a positive Lyme test, We don't see the rash, which only appears in 50 or 60% of the cases anyway.
And there are 17 different rash types as
Well,
well?
the rashes look pretty much alike, okay? But they can appear anywhere on the body at any one time.
Or not, right?
Or not, yeah. 50 or
Right.
60% of the time, they never show up. And actually, they can show up on your back and you'll never see it. You have to have someone else looking. So the rash is one thing, but if the symptoms start to persist, especially in the spring and the summer now, there is, in an endemic area like Massachusetts, be it Cape Cod or up along the coast, the North Shore, even out to the Berkshires, it's important that you get a really good lab test, because the physicians, Lyme disease is as a friend of mine, Ed Masters, used to say, Lyme is a clinical diagnosis until you make it, because once you make it, it actually becomes almost a political statement, and it's a divergence of thought that drives this, it seems, away from the patient and into the political arena. And we really need to take care of the patients, because the Lyme disease is getting worse. There is no, the ticks are proliferating, the deer are proliferating to carry them through the winter.
Well, let's wrap up shortly.
Sure.
You know, and I hate to do this, but let's leave the viewers with some practical advice if we can.
Okay.
You know, the obvious. I mean, how do we protect ourselves from ticks and other parasites that might be transmitting disease? What about DEET? What about essential oils? Are there any products that you use?
There are a number of products, and my expertise actually isn't into that, but there is a pretty good website that I try to hand out, and it's run by Tom Mather down at the University of Rhode Island. Tom's an entomologist for the state and Rhode Island. It's called tickencounter.org. And although we don't necessarily always agree on treatments or following which guidelines once you get to the diagnosis, he tests virtually everything you could put on your body, and that's a good website
That's
to go.
helpful. That's very
That
helpful.
one, and you could try Lou Magnarelli's site down at the Connecticut Agricultural Center. They're a little more involved to navigate that website, but both of those websites have a lot of pretty good information on them about what you should do to try to protect yourself besides just staying out of the woods.
Excellent, excellent. So, I mean, as you can see, and as the viewers can see, I mean, we're just scratching the surface on these very complex topics. At the end of this program, we'll leave reference sites that
Sure.
Bob mentioned,
Yeah.
my own contact information as well. So I just want to thank you for joining us today, and I wish you peace and good health to you always.